And you know, it's interesting because recently there's been tremendous importance trying to teach healthcare providers to recognize familial hypercholesterolemia, which is not a rare disease, the heterozygous state. It's one, depending on your population, between every 250 to 500 births. So it is the most common monogenetic disorder out there. So, but you know, LP little a is just as common. It's almost 1 out of 4 that have. There's a brand new foundation, and I would suggest our listeners Google it, the Lipoprotein little a Foundation. Rightfully so, there's such tremendous importance being put on FH, but LP little a is out there, and I'm of Tara's mindset that as a part of your cardiovascular risk assessment, it only has to be done once in your life. If you're ordering a lipid panel for the first time on somebody, why not how are you ever going to pick up these people who are going to wind up in the CCU unexplained, because the lipids may not always explain it. With FH, the lipids are going to explain it. You're not going to miss an FH with a lipid panel, but you might with LP little a. So I think this is one of the newer things that guidelines now sort of say, oh, in people with strong family history, or certainly everybody who's had an event. And it's amazing how many people come to anybody for cardiovascular workup who, even with events, have not had an LP little a check. And whether there's something we have to specifically use to treat it or not, I think our standard goals of therapy probably become more aggressive in such a patient and everything here. So if we look at the lipoprotein analysis that John got back on this patient, ApoB is 91. That's approaching the 50th percentile for an ApoB, so that's high. The LDL particle count was 1,400. Depending whether you look at Mesa or Framingham, that's 50th percentile or even higher for particle count. The LP little a mass remained high here, a little bit different than it was, but it's still in the significantly abnormal range. Although I say different, I believe the first one was measured in millimoles per liter, and this one is in milligrams per deciliter. And then, there are LP little a treatises on our website. Without getting into it, there is no assay that measures APO little a in millimoles per liter. What they've done is measured in milligrams, and they use a conversion factor to create it. But since ApoA isoforms vary tremendously between patients, you don't know the molecular weight, so that is a very inaccurate calculation. And I think for now, you just ought to stick to milligrams per deciliter, or guess what? There's a new test coming out. It's LP little a particle count. And we have to develop a lot of information about that, but that might ultimately be the test you really need to know, and maybe that's something that we should see if lowering that matters or so. So we do have to respect. So what did you do to this patient, John? What was your approach to off the atorvastatin, where you still got the lipoprotein little a issues, your lipid profile is abnormal again, and clearly I think there's too many particles. So what did you recommend?
No, that was the part that made the difference, is that since we had the triglyceride HDL ratio that looked good and might have predicted that she could have had a low particle count, which we certainly could have made a condition to not treat, like we've talked about on some of the other videos, and the particle count that's elevated, this was the tiebreaker. So she did have an elevated particle count, she has a high LP little a mass, and it was something that, by seeing that, her disease process, atherogenesis, is coming from the ApoB particles. Driving into the wall, higher concentration, gradient driven, all the things that go with that. So it looks like she needs to have treatment to bring this down. And of course the statin is that's the drug of therapy to go after this. So what I did initially was, now that I see that I have the LDL particle count that's elevated, I decided to put her on a statin. And then the next question is, do I do something to try to treat the LP little a, which becomes part of that discussion as well. And at this point, the only thing that we know that does a good job or has any kind of discussion towards it is the use of niacin. So I started her on niacin as well.
So if you go statin alone, on your subsequent lipid profile, I bet you're going to see with the last doctor, your lipids, even I bet your total LDL particle count is going to look considerably better, but you're not going to touch the LP little a mass. And by the way, the reason for that is statins upregulate LDL receptors, which remove normal LDL particles. But when ApoA attaches to an LDL particle, it actually camouflages the part of ApoB that the LDL receptor grabs. So the statin is never going to remove an LDL particle with ApoA on it. it's just going to remove the other particles, which may get you to LDL cholesterol goal, as happened in this case. I hope it gets her to LDL particle goal on follow-up or so. But then you still might have the issue that ApoA mass is up, or if you start measuring it, Lp(a) particle count is up. So what can we do nowadays? Now, John's suggesting niacin would be in that room. John can't produce a study that shows me adding niacin to that is going to cause event reduction. But is that inappropriate? Would you consider adding niacin to the statin in this case?
I would do the same thing. I absolutely would consider at least adding niacin to the mix, and I think being on statin also makes sense. I may put the patient on a combination of the two, and even just a peanut generic statin with, with niacin combination may be enough.
I did look. I put her on a Torva20 and niacin ER, extended release 500.
Sure. So you're going to titrate up with
Yes.
that niacin.
Yes.
You always start lower.
It'd be interesting what even niacin monotherapy would do here. I mean, whether you get with a 1400 particle, you may be able to achieve a particle reduction under 1,000. That's another option.
So what you're hinting at is, regardless of what niacin even does to ApoA, and it's going to lower it to a variable degree, which is unpredictable. It might be a lot, might be a little bit. But you're probably going to get additional ApoB, LDL particle lowering, which is always mission number one right now, sticking to the evidence-based therapies or so. But, I guess you guys don't know that niacin just failed in 2 big trials where you added it to a statin. I'm being facetious here. Of course they know the AIM-HIGH and the HPS Thrive, which are niacin upon statin, were null trials. It didn't work. Not that we have any serious data on the Lp(a) people in those trials or so. The little bit that snuck out doesn't seem to matter, but we have to see how many there really were. But why would you want to be adding niacin? It didn't work. But here you have a patient that you think maybe it would work or so. So just a quick word of why it probably didn't work in those trials. And is niacin dead as a drug?
Right. So I use niacin now, and I used niacin a decade ago to lower ApoB and lower LDLP. I really don't care what niacin does to HDL, and it actually may have nothing to do with its benefit. In fact, those trials were looking at whether or not raising HDL cholesterol in the setting of a low HDL cholesterol is going to further impact disease in patients that were already very aggressively treated to both very aggressive LDL cholesterol goals as well as ApoB non-HDL levels that would be considered optimal. If a patient came to me with an optimal ApoB, optimal, certainly non-HDL cholesterol, that's not the kind of patient that we think about adding niacin to. At least I certainly don't as a lipidologist. So all these trials basically told us is if you have a low HDL cholesterol and you've got optimal apolipoproteins, including ApoB, LDLP, raising HDL cholesterol with niacin doesn't add additional benefit, but it doesn't tell us anything about niacin's benefit in the setting of elevated ApoB, LDLP. There are lots of patients that will not get to their ApoB, LDLP goals with statin monotherapy. In fact, the majority, especially those that are high risk, are going to need combo therapy.
And in AIM-HIGH, the patients' demographics were they were allowed to be on any medicine they needed to add on to keep an LDL cholesterol under 70. Their ApoB was around 80, and their triglycerides around 163 or something like that. So these are people who wouldn't even necessarily qualify to take niacin in the first place. Right. And it was just a trial that got the result that it probably should have because it wasn't the right patient to be studied.
So there's plenty of room for niacin nowadays when we haven't achieved ApoB, LDLP, non-HDL goals, whatever you're using or so. And Tara drove home the point, nobody should be using it to modulate HDLs in any way specifically. Even though HDL cholesterol goes up, both of you know HDL particle count doesn't go up. If there's ever going to be a goal for HDL, it's probably going to be a particle count, and we're not even close to saying that yet. Preliminary data looks in that direction. And let me just give you my experiences, and you guys are both family practitioners with a heavy emphasis on lipids, but for the last 10 years, I've only been treating the total nightmares people, sent to me like, and in those type of super high-risk patients, these are usually people on their 3rd or 4th stent, recurrent events, nightmare family histories with Lp(a) issues and serious LDL particle counts. It often takes triple therapy, ApoB lowering therapy. So it's a statin, it's niacin, but ezetimibe can be very helpful in this setting at achieving ApoB goals or something too. And just a little aside, because those of us doing a lot of advanced markers always look at synthesis and absorption too. And one of the downsides to a statin, the reason it is even better on LDL particle lowering, in some people it induces overabsorption of cholesterol. And believe it or not, in that great Hatch trial where niacin and statin certainly seemed to convey arteriographic regression, small trial, event reduction for what it's worth, niacin did not negate the hyperabsorption of sterols, actually worsened it a tad. So especially if you're monitoring sterols in a patient using a statin and niacin, that might be, wow, a little ezetimibe to the rescue for perhaps even another reason here. So, and it just goes to show you with people with bizarre disorders, not that Lp(a) is bizarre, it's not even rare, they deserve careful approach. One other thing, John, are you going to use an aspirin or an antiplatelet drug in this woman? Is Lp(a) a thrombotic risk factor?
Yeah, it's got that prothrombotic effect, so an 81 milligram aspirin would be a good choice to put on.
Yeah, I agree. Actually, in people with extreme elevations, there's even venous thrombosis that has been associated with Lp(a). So I don't see the downside in a very high-risk person to throwing it or so. Any possible way to monitor that in a patient nowadays, Tara? If you do throw aspirin, somebody is, how do you know it's working?
Sure. So it's always hard to know, especially in the younger patient population, they're under age 60, under age 65. We always don't know, especially in a woman, should we give them aspirin or not? Is there benefit? Trials don't necessarily tell us that. So if somebody's on aspirin and we want to understand whether it's, whether it's working properly or not, we could do a urine aspirin works test to determine whether they still have very activated revved up platelets. And if they do have really activated revved up platelets based on that test, they clearly need potentially a higher dose, 161 milligrams, or they maybe have some resistance to the aspirin. So it may be real reasonable to monitor. I actually consider doing the test too if I'm on the fence about whether I should be adding aspirin or not. And I've got a patient with an aspirin works test that's just through the roof. They're not even on aspirin, but it's through the roof. It suggests they've got very activated platelets, and being on an aspirin, even a baby aspirin every other day, when we put that on, they'll oftentimes normalize that test. So it kind of helps it in this day and age where we really need to personalize and individualize therapy, and we just don't know what to do. We may have an answer for a population, but we don't have an answer for an individual. We need to be able to find ways to fine-tune that therapy.
Great point. And especially in women, aspirin use has become controversial. It's not always so clear. With men, it's pretty clear as their risk factors mount up. But in women, the data is funny, and that's perhaps one way of, I think if I saw urinary thromboxane, a marker of platelet reactivity abnormal, unless there's some real reason not to use it in an Lp(a) setting, I would. Well, thank you very much for viewing this, and I hope that you can take some of these principles and apply them to all of your patients.